Good evening. This is Dr. Darshan. And as we approach the third Wednesday of the month, we start with our new session of Indian Society of Nephrology Journal Club. This month, we are starting a new segment called The Last 3 Months in Nephrology, where we will critically analyze all the interesting journals we have come across in the high impact journals of nephrology. So it would be Kidney International, AJKD, JASN, CJASN, Transplantation, and NDT. These are some of the journals we have gone through, and we have picked up a few interesting articles which can make clinical implications and changes in our practice. So to start with, I'll be presenting two articles today, one from the Kidney International and other from the AJKD, which has been published in the last 3 months. Uh, uh, can you help can you help me to share the screen? Uh, yeah, just a moment. Yeah, thank you. I hope my slides are visible.
Yes, sir.
Yeah. Okay. Thank you. Okay, to start with, this was the study which was published in KI, which compared the accelerated hepatitis B vaccination versus the standard hepatitis B vaccination in patients with advanced CKD. When they say advanced CKD, it is stage 4 and beyond. This was a multi-center study which was done in Thailand and was published in Kidney International. So let's go with a few introductory slides. Chronic hepatitis B infection is one of the leading causes for cirrhosis and hepatocellular carcinoma. The global prevalence is about 3.6%, and 248 million individuals are affected across the world. HBV vaccination before CKD stage 5 is usually recommended. This because improved seroconversion. Studies on patients in dialysis have shown a poor seroconversion as low as 22% on hemodialysis after 3 doses, which increases to 48% after 4 doses. So the seroconversion on hemodialysis is very poor. So that's the reason try to vaccinate them early, and this helps to prepare them for a transplant also, other than being them on dialysis. So the standard hepatitis B vaccination is the recombinant hepatitis B vaccination. What we use the double dose, that is 20 microgram in each intramuscular injection in each deltoid on 0, 4, 8, and 24 weeks. This is the standard regimen. In the accelerated regimen, it is the same strength, that is the 40 micrograms, 20 micrograms in each arm, but we are doing it at 0, 1, 4, and 8 weeks. So we are completing the entire 4 doses within 2 months rather than the standard 6-month protocol. So the seroconversion is defined when the anti-HBs titers are more than 10. This is the standard definition. So there is limited data to inform the usefulness of this patients. It is already seen that the accelerated vaccine protocol in healthcare workers with a normal renal function has shown robust immune response. We wanted to see if this strategy works in advanced CKD patients too. So this is a randomized control trial in which block randomization was used. The block size was 4. 3 tertiary care hospitals in Thailand between August 2021 to December 2022 enrolled patients. They calculated a sample size. The sample size was adequately powered with 80% power and a two-tailed significance of 5% significance. And they said that 60 people in each arm was sufficient. They counted for the dropouts and 10% dropouts, and they suggested that 66 in each arm would be an adequate sample size. So that's how the number 133 patients, 68 in a standard arm, 65 in accelerated arm was arrived. So the primary outcome was seroconversion rate at 12 weeks after the vaccination, after the first dose of vaccination. At the end of 12 weeks, day 0 to day 12 weeks, you see the seroconversion. The secondary outcomes is what was the seroconversion at 6 months, what was the seroconversion at 1 year, and how many percentage of patients had more than 100 international units as their antibody titer. This is because if the titers are more, they are going to have a longer protection. So that is the reason that any person with a titer of more than 100 at end of 1 year was counting on a long-term protection. So participants who were lost before 12 weeks were thought to as non-seroconverters in the intention to treat analysis. When they were analyzing for the primary outcomes, if they were lost to follow-up, they were converted. They were included as non-seroconverters. So let's look at the inclusion criteria. Someone who is more than 18 years of age with an estimate with an CKD stage 4 and worse, and with an anti-HBs titer of less than 10 were included. Exclusion criteria was prior history of hepatitis B vaccination, HIV infection, or any other seropositivity, not HCV, HBsAg core antibody positive, and any recent immunosuppressive drugs were excluded, or allergic to vaccination. These were the patients who were excluded. The standard exclusion criteria. Let's look how the study went ahead. After enrollment, a detailed history of vaccination, if the patient was vaccinated prior, was recorded either by questionnaire or by medical records. So if you look at the standard arm at the first month, second month, third month, and at the end of the fourth dose was at the end of 24 weeks. So if you look at the weeks, so the first dose was at the start point and at the end of 1 month, second month, third month, and at the end of 6 months. This is what the standard protocol is. And the titers were checked at the end of 12 weeks, 28 weeks, and 52 weeks. In the accelerated arm, which was the study inclusion criteria, CKD stage 4, 5, or on dialysis. So 0, 1, 4, and 8 weeks were when the vaccination was administered, and the first anti-HBs titer was collected after 4 weeks after completion of the 4 doses. So the first titers, if you look at, this is where the primary outcome we are measuring. In the standard arm, it was collected after 3 doses, while in the accelerated arm, all the 4 doses was completed, and then the anti-HBs titer was measured for the first time. So this is just the flow chart. A total of 1,600 patients were screened, and finally, at the end of the follow-up, after taking a detailed inclusion and exclusion criteria, there were 65 in the accelerated arm and 68 in the standard arm. And when you further analysis at the end of the thing, we could say that 63 patients completed the 12-week protocol sampling, 52 completed the 6-month sample, and 39 patients completed the 1-year sampling in the accelerated regimen, and almost similar number in the standard regimen, with more patients completing the 1-year survey. So if you look at the results, what we could see is there were about 12 to 15% of patients who have had previous vaccination but had a lower or a negative titer at the time of enrollment. About 60% of patients were on hemodialysis when they were included. So that when we say 60%, another 40% were in CKD stage 4 and 5 non-dialysis population. So 10% on PD, around 15, 60% on this. So let's look at the results. Sorry. If you look at the results, what we can realize is at the end of 12 weeks, if you measure the anti-HBs titer, 16 to 20% rise. There was a 16 to 20% absolute difference in the anti-HBs titer between the standard protocol as well as the accelerated regimen. If you look at this, this is the right side is my accelerated regimen, and there was 16 to 20% higher anti-HBs titer among patients with an accelerated regimen. This is expected because they just in the standard protocol they had just received 3 doses, but with the accelerated regimen they had already received 4 doses at the week 12 when the sample was collected for anti-HBs titer. Similarly, in the group where anti-HBs titers more than 100 was seen, there was a 16 to 20% absolute difference between the two groups. So what does it say is accelerated group had a higher anti-HBs titer, probably because they had already received all the 4 vaccines by the end before 12-week measurement. So this is what is shown in the bar graph. Similarly, when you are looking at the secondary outcome, which is measured at the 28 weeks and the 52 weeks, this is interesting. We can see that, yes, at the 28 weeks, you can still see an absolute difference, but as the 52-week mark approaches, the standard regimen had a more higher titers of more number of people with protective titers. So this is something interesting. As we go as the follow-up increases for 6 months and 1 year, the anti-HBs titer is more robust in the standard arm. So if you look at the same is represented here at the week 28, the accelerated group had a higher absolute difference, but as you keep on going, the accelerated the titer starts dropping down, and especially in the more than 100 group, you can see that the accelerated group had fewer patients at the end of 1 year. This is nothing but the geometric mean concentration. Whenever we are looking at the efficacy of a vaccine, we look at the geometric mean concentration. This is the standard protocol measurement to determine the vaccine efficacy. Where there are three terms in this: geometric mean concentration, geometric mean concentration ratio, which is nothing but the logarithmic scale of the geometric mean concentration, and there is something called as a geometric mean titer, especially when we know what is a protective titer. In a hepatitis B, we know that protective titer is more than 10. So then we can also use what is known as a geometric mean titer. What does it all these tell is for any vaccine efficacy, we always take the logarithmic scale. That is why the geometric mean comes. So whenever you are using the logarithmic scale, what we can see is we to look at the vaccine efficacy, we use the geometric mean concentration. And what we see again, what was reflected in the previous primary and secondary outcome, we see the same. In the first 12 weeks, yes, the titer is very robust. But as the time passes, as it is 6 months and it is 1 year, the standard group have more patients on the protective titer and more than 100 titers. There are more people in the standard group arm than the accelerated group arm. Even though it was not statistically significant, but yes, probably if we had a more sample size, then probably it would have made more sense, and the standard group would have shown more robust efficacy at the end of 1 year. This is a secondary analysis or the post hoc analysis where they have seen what patient groups have more an accelerated response to the vaccine. All the difference was only with the age. Advanced age people do better with accelerated vaccination than the less than 60 group. Someone who is more than 60, what does this say is someone who is more than 60 years, they do well if you use the accelerated protocol of 0, 1, 4, and 8 weeks. The rest all there was not statistically significant. Only the age was the one which was contributing, and it favored the accelerated group. So in conclusion, the accelerated hepatitis B vaccination regimen demonstrated significantly higher conversion rate at 12 weeks. And this is probably because they had received all the 4 doses compared to the standard hepatitis B vaccination. Especially if you look at the per protocol analysis, in simple terms, what it stated that for every 100 accelerated vaccinations, we would expect an additional 16 seroconversion and anti-HBs titers of more than 100 responder than someone receiving a standard vaccine schedule. This is in simple terms. So for every 100 patients with you will see another 16 more seroconversion with accelerated. This is at the 12th week. But participants in the older age group achieved significantly higher levels of seroconversion in the accelerated group compared to the standard group. This approach can be considered as effective option for achieving rapid seroconversion, particularly before hemodialysis initiation and in preparation of a kidney transplant. So for especially if you're seeing anyone who is going for a transplant in the next 3 to 4 months and you want to have them a rapid seroconversion, this is accelerated seroconversion strategy works well, or someone who is going for a hemodialysis in the next 3 months, accelerated seroconversion strategy really works well. Okay. We'll take up the questions at the end of the sessions. So the next study is is from the AJKD, and this is another clinically interesting study about association of implantation biopsy findings in living kidney donors, with both looking into the donor and recipient groups. So let's look into some of the why this study was necessary. We already know that the kidney donor profile index has been used extensively in most of the disease donor programs in the Western world. Anyone more than 85% is rejected. KDPI score of more than 85% is rejected, and that has been really worked well if you look at the 10-year outcomes or the 5-year outcomes. So can something similar be introduced in the live donor? That is what we tried to look. So these pre-transplant assessment typically incorporate donor demographics, kidney function surrogates such as EGFR, proteinuria, in US they also include kidney biopsy data. So in India, we don't do often the implantation biopsy, but in most centers in United States, even in the living kidney, they have a implantation biopsy. tools that use such information may have prognostic utility for kidney graft and recipient outcomes and even help predict post-donation outcomes in the living donors. So there has been previous living donor kidney implantation biopsies which have evaluated morphological characteristics, especially looking into the nephron size, number, chronic changes such as glomerulosclerosis, IFTA, or arterial thickening such as arteriosclerosis. And there have been mixed results when it comes in. That's the reason the group they wanted to see what are their outcomes from their hospital, from their university. So the investigators had prior work where they had demonstrated association between histological findings and implantation biopsy and graft outcomes among deceased donors. They had already published their outcomes on deceased donors and implantation biopsy. So they now wanted to look into living donors and implantation biopsy and their outcomes. So the group had extensive experience on similar studies. So this was a retrospective cohort from North America between January 2010 to July 2022. So the objective was to identify the prevalence of chronic histological changes and glomerular disease in donor kidneys. So what is the percentage of chronic changes and their association with donor and recipient outcomes? The study had very clear objectives. So the outcomes in donors was what was the in the donors, they looked into single kidney EGFR increase post donation, percentage of total EGFR loss post donation, and then how many more than 40% EGFR decline from pre-donation baseline and an EGFR of less than 60 ml at 6 months after donation. These were the outcome measures which were assessed in the donors. In recipients, they looked at death-censored allograft survival. So they had they had close to 1,300 biopsies which were eligible. And at the time of assessment, close to 1,200 biopsies were taken in for inclusion criteria. And at the final number came up to 1,100 because in the inadequate sample size were all excluded. And at the end of the day, 1,100 samples were excluded. For donor assessment, 300 donors were lost to follow-up. So only 800 donors were evaluated. Okay, let's look at the biopsies and how they were scored. Biopsies were closed based on the retrospective review. So glomerulosclerosis were graded as 0 and 2. It was a simple less than 25%, more than 25%, or no glomerulosclerosis. IFTA was again divided into 0 to 3, less than 5%, 5 to 25%, 25 to 50%, and more than 50%, a 0 to 3 score. Arteriosclerosis was graded as mild, moderate, and severe. So any score of more than 2 or equal to 2 was considered as chronic change. If someone has a GS score of 2 was considered chronic. If someone had an IFTA of more than 2, that is more than 25% IFTA was considered as a chronic change, or if someone has a moderate arteriosclerosis was also considered as a chronic change. So any score of more than 2 was considered as a chronic change. And this is how the GFR estimates were done. GFR estimation was based on the CKD EPI score, 2021 equation. And what they did was single kidney EGFR was defined as EGFR 6 months post-donation minus EGFR pre-donation divided by 2. This was the single kidney EGFR increase at 6 months. Similarly, percent total EGFR loss at 6 months was defined as EGFR pre-donation minus EGFR at 6 months post-donation times 100 divided by EGFR pre-donation. These are some of the simple calculations they use to measure the GFR, estimate the GFR. So if you look at the total number, 1,100 were included in the analysis. 85%, there was 1% of population who had an incidental change. So this is very important. There was 1% of population which had a incidental a change, sorry. Let me just go. Incidental change. About 14% had chronic changes on the implantation biopsy. 85% of patients had a normal implantation biopsy. So if you look at the age, the higher the age, more is chronicity in the implantation biopsy. This we all know, right? We do know that the higher the age, the more. Females had higher chronic changes. I'll just get to the factors which came into which actually made relevance. While it was presence of hypertension was more associated with chronic changes, a family history of end-stage kidney disease were more associated. So these are some of the things which contributed. This is just the initial table. I'll go into the results one by one. So if you look at the logistic regression, what you can realize is every decade a donor is as the decade for every decade older in donors. For example, a donor who is 50 years had more chronic changes compared to a donor who was 40-year old. So for every decade old, the donor being old, the chronicity in the implantation biopsy was observed. Similarly, females had higher chronic changes on the unadjusted odd ratio, but with the following adjustment of all the other factors, the main significant factors were Hispanics, older age groups, presence of a hypertension, pre-existing hypertension, and presence of urine albumin creatinine ratio of more than 30 milligrams. And these were the standard definitions which predicted chronic changes. These were standard clinical predictors which also predicted chronic changes on the implantation biopsy. So notably, all these donors had a family history of end-stage kidney disease. 75% had a family member with glomerular disease. 25% had at least one urine analysis with microanemeturia, and none had pre-donation urine albumin creatinine ratio of more than 30 milligram per gram. So if someone who does not have a chronic changes, that means most often it is if someone doesn't have a chronic changes, most often they usually are much younger, and usually they do not have hypertension, or they do not have a family history. Let's look into the overall box and whisker plot. So what we see is, if you can see here, the mean single kidney EGFR increase at the end of 6 months was similar in all the groups. In the group with the chronic changes, in the group with the normal histological variants, there was not much change at the end of 6 months. If you look at the EGFR, there was only a difference of 2 ml between the groups, between group with the chronic changes and between the group with the normal histological variant. There was a negative correlation between donor age and single kidney EGFR increase for each group. We have already seen that. So with increasing age, you have decreasing EGFR. So this table again talks about the same thing. This is an adjusted linear regression model, which showed there has been no association of chronic changes with single kidney EGFR increase, or the relative risk of total EGFR loss of more than 40%, or developing CKD or entering CKD stage 3 was not seen at the end of 6 months in patients who had chronic changes on implantation biopsy. So what does it say? Presence of chronic changes on implantation biopsy did not contribute to predicting CKD stage 3 at the end of 6 months. Let's look at the recipient. What happened with the recipient? Even with the recipients, presence of chronic changes in the implantation biopsy did not make any change at the end of 6 months, or even at the end of 10 years. The death-censored graft failure was similar in both the groups. So what does it say? Approximately 1 in 7 living kidney donors had chronic changes on implantation biopsy, primarily in the form of moderate vascular disease, and 1% had possible donor glomerular disease. Abnormal implantation biopsy findings were not significantly associated with 6-month donor EGFR outcomes or allograft survival. So what has the previous studies contributed? Previous studies have taken IFTA of 5%, and they have shown that one of the positive studies which had contributed as similarly a large Mayo Clinic study said that a presence of more than 5% IFTA had a death-censored graft failure, had an increased death-censored graft failure at the end of 6.3 years. This was a study which gave a positive correlation of implantation biopsy chronic changes and poor graft outcomes in the recipient. But what actually makes sense is development of what these studies had is these studies actually contributed to the development of living donor kidney quality assessment tools. In future, we can develop AI models and machine learning models which will include all these things and contribute and develop a score similar to a KDPI score, which can tell us how long does a graft last, and whether the donor becomes CKD stage 3 in a 5-year follow-up. So finally, should transplant centers that do not routinely perform implantation kidney biopsies change their standard practice? No. The answer is no, based on the studies. Routine implantation biopsy has some merit. The merit is if you do a biopsy in a renal transplant recipient, An implantation biopsy helps to differentiate whether this is donor derived versus de novo chronic histological changes. So if you're doing a recipient for some rejection and if you see that there are some chronic changes, a implantation biopsy helps us to see whether this was donor derived or whether these are de novo chronic histological changes. The other additional thing about implantation biopsy is additional incidental silent globular diseases can be picked up. As in this study, 1% of silent globular disease were picked up in the donor so that they can be more closely followed up. Investigator noted that arteriosclerosis on implantation biopsy was independently associated with subsequent development of hypertension in living donors. So yes, there is some merit, but should it be a routine practice? No. Thank you. I'll ask now Dr. Vivek to present uh, his studies about for the last 3 months. And I'll stop sharing. Vivek, are you ready? Vivek?
Yeah,
Yeah.
yeah. Thanks, Dr. Krishnan.
Yeah. I'll stop sharing. So,
Yeah,
yeah.
I'll share my screen. Just a second. I hope you see my screen now.
Yeah. You
Yeah.
can go ahead, Vivek. Yeah.
Yeah. So good evening, everybody. So today we have two, I would say, phase 2 clinical trials. One is a combination of Verenurad with allopurinol in chronic kidney disease, and another one is addressing the issue of recurrent FSGS after kidney transplantation. So the first clinical trial was a combination treatment with Verenurad and
Vivek,
allopurinol.
do you have any message in this slide? Because it's a blank slide. What we have is a blank slide.
Oh, blank. I don't know.
Okay, it's a blank slide. Okay.
Is it coming now or is it still blank?
It is still blank.
Oh, I. Is it still blank?
It is still blank.
Sir,
Yeah.
please stop sharing and share again.
Okay. Okay, I'll do it.
No, we can only see the cursor moving around. Wait,
No?
no, only the cursor is moving around, and we can see the pointer moving around, but not the slide.
Oh, I don't know what is the
Sir, I
issue.
think your file is not open properly.
Okay, I'll just close it and maybe just open it again. I'll stop sharing and do it. Maybe I'll. Oh, okay. I'll just see if it's all right. Otherwise, I think if it helps this time, it's all right. Otherwise, I think Dr. Arun can present. Let me just open the file again. It's opening.
Vivek, it's the same. It's a blank slide with the pointer moving around.
It, you don't see any of the
No,
content in
no,
the slides?
no, we don't see. Arun, are you ready?
Yeah,
Arun,
Hi, sir.
yeah,
Yeah,
you can start, Arun, and probably Vivek can present at the end of your
yeah,
present. Yeah. You can stop sharing, Vivek.
yeah.
Arun, yeah.
I've stopped sharing.
Yeah. You can go into the presenter mode. Yeah, perfect.
So, very good evening to all of you. So, today I'll be taking one article from NDT and one from CJASN. Both are sort of epidemiological type of studies, and which I felt was critically important, which were published in the last 3 months. The first one was from CJASN. It is about the significance of hematuria in podocytopathy. It was published in January. Overall, the risk for progression of CKD and incident CKD, it is there is because of hematuria is known in various renal diseases. However, with regard to podocytopathies, the risk is still uncertain. The mechanism how hematuria leads to renal damage is either through free heme toxicity or through a GBM abnormality. Many studies across all continents have shown that hematuria increases the risk of CKD. One of the last studies were published in 2022 in AJKD, where it was very unequivocally shown that microhematuria, it increases the risk of incident CKD, especially if it is persistent. So overall, podocytopathy is heterogeneous group of diseases, and even within each disease, the course is variable and it depends upon multiple prognostic biomarkers. And almost many cohorts, they have shown that nearly 1/3 of the patients can have some type of hematuria. Overall, the assumption for this study was that hematuria would be associated with lower rates of remission of proteinuria and also greater decline in kidney function over time, even in patients with podocytopathies, irrespective of the proteinuria and the renal. So this study was done with the aim to determine the prevalence of hematuria in both adults and children with proteinuria kidney disease and a biopsy-proven podocytopathy, and also to assess the association between prevalent hematuria and clinical outcome. This included two major cohorts. One was an NEPTUNE cohort, which is a nephrotic syndrome study network. This was initiated in 2010, which is a multi-site collaborative study which collects data from patients who have biopsy-proven FSGS, MCD, and MGN. So during the first year when the cohort was formed, those with proteinuria even more than 0.5 PCR are included. However, from the second year, only those above 1.5 are included for the collection of data. Pediatric patients were included if they are presented with nephrotic syndrome even without a biopsy. And Alport syndrome were included for this entire cohort of NEPTUNE. The other cohort which was included for analysis in the study was a CURE-GN cohort, pure glomerular nephropathy cohort, which is the largest observational cohort of both adults and children with glomerular diseases. It is functioning since 2014. And most of the patients of NEPTUNE cohort are on follow-up in CURE-GN cohort also. There was some overlap between both cohorts in that with the participant data. This was funded by the National Institute of Diabetes and Digestive Kidney Diseases from the US. And in this, FSGS, MCD, MGN, and IgA nephropathy patients were included in the cohort. But for the study purpose, IgA nephropathy patients were excluded because the prognostic significance of hematuria and IgA nephropathy is already. So only FSGS, MCD, and MGN patients who had a minimum of 3 urine analysis and at least 2 years of follow-up were included in this study. And they should have had at least 1 to 3 clinic visits per year in the preceding year. Then only they were included for analysis. The outcomes which were analyzed was the composite of time from the initial urine analysis to 40% decline in EGFR to a value of less than 60 ml or up to kidney failure, and also to time of complete remission, which was defined as a urine protein creatinine ratio of less than 0.3 in those patients who had a protein creatinine ratio of more than 1 at the first study urine analysis. Only for more than 1, this proteinuria outcome was being measured. So the primary exposure for us was hematuria, which was classified as small, moderate, and large at the local laboratory using an automated device. No hematuria was classified if the dipstick was a trace, negative, or if it showed hemolyzed for blood. The covariates which were assessed were at the time of the first urine analysis was the GFR, which was measured by the Schwartz equation if it was less than 18 years. More than 26 years, the EPA equation was used. Whereas if it is 18 to 26 years, the mean of both the equations, GFRs, estimated GFRs were used. Data with regard to demography, physical examination, self-reporting, antihypertensives, and immunosuppressants were collected. Genetic reports, genetic evaluation was available for 319 patients in the NEPTUNE cohort, and we'll be seeing the importance of that data. With regard to the baseline characteristics, 1,516 patients were included in this study. of which one third, nearly one third, 498 patients had some degree of proteinuria. So if you can see the three categories of disease, FGN, MCD, and FSGS were equally distributed in the entire cohort, around one third totally. And with regard to the difference between patients with and without hematuria, patients with hematuria tend to be older, 37 years versus 33 years, and a significant number of patients had membranous nephropathy, 44% whereas 27%. Apart from this, both the groups were on the overall quite similar. With regard to the proteinuria and the biopsy history, uh, around 26% of the patients in the entire cohort had very less proteinuria. This was probably because the time lapse between the biopsy and the assessment for the inclusion in the cohort was higher, so that they would have received some sort of immunosuppression and the proteinuria had gone into remission. And between patients who had hematuria and non-hematuria, those with hematuria had a significantly higher incidence of nephrotic range proteinuria, 59% as against 26%. One other difference was that the days since the biopsy was done, it was significantly lesser. That is, patients who had more recent biopsy tend to have more severe hematuria. Those who had hematuria had been biopsied with a mean of 139 days in advance, whereas others had a biopsy even up to 325 days earlier. So with regard to the age, diagnosis-wise, sex-wise, and age category-wise differentiation, you can see that the prevalence of hematuria, as seen by the maroon flow chart, it is quite similar across all age groups. MGH significantly had more hematuria than the other two categories. Those with significant proteinuria more than 3 UPCR had a more hematuria than the other categories. Apart from that, it is quite similar across all the baseline characteristics. When the patients with proteinuria more than 1, UPCR of more than 1 were assessed, patients with membranous were significantly different between the groups. So 46% of the patients had membranous among those with hematuria, as against 35% in those without hematuria. Apart from this, both the groups were quite similar. Here again, the day since biopsy, there was shorter time for a biopsy in those with hematuria. So these were the only two significant things in the group differences between patients with and without hematuria. In the survival estimates were done, the time to kidney failure or 40% decline in EGFR, it was significantly shorter in patients with hematuria as against patients without hematuria over follow-up of 4.6 years. Whereas the time to complete remission, it was slightly higher in patients with hematuria. So patients with hematuria had a lesser survival and took a longer time to attain remission if they had a urine PCR of more than 1 at baseline. And this is shown in the model. So initially an unadjusted model was done. Later an adjusted model with the cause, age, and other things were done, which had shown that for those with proteinuria, it was significantly associated with a lesser remission if at all they had hematuria. And the supplementary data had shown that patients with hematuria had a higher hazard of kidney failure, and this was similar after stratification by all ages and cohorts. So overall, what the study wants to tell is that if there is a glomerular hematuria, it is because of a defect in the glomerular basement membrane. And in podocytopathies, the extent of hematuria will signify the extent of the glomerular filtration barrier damage. And overall, among all these three categories of podocytopathies, membranous is supposed to have a more prominent GBM alteration, which explains the higher prevalence of hematuria in this. So one point is that whether the patients had a coexisting collagen uh, gene abnormalities because of which they had hematuria. So in the Neptune cohort, around 319 patients had a genetic evaluation done for the collagen gene, out of which only 9 patients had some amount of had a non-significant or a partially significant genetic variant, because of which they say that the entire cohort also we expect a similar degree. So irrespective of the genetic variation, patients with podocytopathies tend to have some degree of hematuria, which can affect outcomes. That is what this cohort study wants to tell. So in comparison, there have been a few studies, study from IPGMR, wherein it has shown that the prevalence of hematuria is around 11% MCD as against 20 to 25% MGN. And similarly, the studies across other continents have also shown that MCD has the lowest incidence of hematuria among all podocytes. The strength being that it is a large population size, follow-up with significant follow-up of 4.5 years. And the follow-up, even after biopsy, was significant. If at all there is false positive because of the biopsies, that can be excluded because the first urine analysis, the later urine analysis was done significant time period after the biopsies. And the one which was used for assessing hematuria was a dipstick testing, which is quite simple. And the inter-observable variability is lesser with regard to dipstick. And limitations, both the cohorts are from academic centers. You can have a referral bias with the patients who have been referred to the center. There can be misclassification because urinalysis was performed only once.
Arun, you're disconnected. Your slides are disconnected. Yeah, you're back. Uh, have you muted yourself, Arun? Yeah.
So the other issue was that the other cause of hematuria, malignancies, nephrolithiasis, the timing of menstrual period were not available in the cohort data. So whether that has affected the interpretation of hematuria may be a limitation for this study. Overall, the conclusion is that hematuria is common even with podocytopathies. They are associated with a higher risk of progressive kidney disease and a lower likelihood of proteinuria remission. Dipstick, it is easily available, inexpensive, and we can incorporate it in our clinical practice, and it may help us in explaining the patient prognosis better in the subset of patients. So this was the first article from CJASN. The other article was from NDT, which was about whether proteinuria and measured or estimated albuminuria. How do these predict the risk prediction for patients with chronic kidney disease or kidney disease progression? So this was the Korean study from the NoCKD group. Overall, chronic kidney disease is a major health concern, as we are all aware of, and proteinuria is considered a cardinal sign of CKD. And whether proteinuria has to be assessed or albuminuria has to be assessed has always been a matter of concern, with guidelines differing with diabetic and non-diabetic nephropathy. Among urinary proteinuria, albuminuria is the most important, and albuminuria is an integral part of the CKD classification at present. So whether we should use albuminuria or proteinuria or combination of both for understanding the progression, risk progression for CKD was what was assessed in these studies. So what we usually do is that a 24-hour urine protein estimation is what is usually used as a gold standard because one, it is easily available, inexpensive, but it is cumbersome and requires meticulous effort from the patient. Albuminuria is expensive as compared to proteinuria, especially in the field setting, and may not be widely available. And whether there is superiority of albuminuria or proteinuria in assessing the risk of kidney failure with replacement therapy. That is, the end-stage kidney disease was what was seen in this study. One other aspect was that albumin-creatinine ratio can be estimated from the protein-creatinine ratio. So whether that formula is useful in areas where albuminuria cannot be measured was the other part which was assessed in this study. So the aim of this study was to compare the predictive performance of the measured spot urine ACR, the protein creatinine ratio, and the estimated ACR converted from the PCR for the risk of kidney failure with renal transplantation therapy, end-stage kidney disease. So the NoCKD is a Korean cohort study for outcome in patients with CKD. It is a multi-center prospective cohort study where 9 centers in Korea were included, and it has been functioning since 2011. From each center, around 250 patients were enrolled from 2011 to 2015. Overall, we had 2,200, around 2,238 patients were enrolled, and after exclusion, 2,099 patients were enrolled in studies, and they are being monitored for 10 years until death or until ESRD. That is the basic cohort from which this data has been obtained. This cohort, it included patients between 20 to 75 years. All stages of CKD were included, and the EGFR was calculated using a 4-variable MDRD equation. Patients who had received earlier transplant or have been on dialysis earlier, significant heart or liver disease, malignancy and pregnancy, or a single kidney, due to either kidney trauma or donation were excluded from this cohort. And the patients were divided based upon the cause of CKD into glomerular nephritis, diabetic nephropathy, hypertensive nephropathy, and polycystic kidney disease. The baseline characteristics for all these diseases are collected, and the serum and urine samples are collected on a regular basis. And renal event, it was defined as a more than 50% decrease in EGFR from baseline value, a doubling of serum creatinine, or the onset of end-stage kidney disease. So the main exposure was to analyze whether the proteinuria can be either ACR or PCR or estimated ACR can be used interchangeably in the non-American four variable kidney failure risk equation. The kidney failure risk equation uses the urine proteinuria assessment, the sex of the patient, age, and the GFR through MDRD, and it projects the risk of kidney failure for the future. So it usually necessitates the presence of measured ACR. So if at all you're going to use PCR or an estimated ACR, whether the equation is still useful was what the study analyzed. And the estimated ACR was calculated from PCR using a very complex equation, as you can see. And this was used for estimating the ACR in this study. The primary outcome was the 5-year ESRD risk, and the ESRD, it was defined as need for dialysis for 3 months or kidney transplantation during follow-up. The secondary outcome was the 2-year risk for kidney failure with replacement therapy. And statistics, the area under the receiver operating curves were used to measure characteristics. And one interesting aspect was the use of net reclassification index and an integrated discrimination improvement index. So these are usually used for diagnostic tests for us to understand the utility. They're quite complex, and I felt that probably we should have a statistician to explain this, which we'll try to have a statistician explain this during the next Zeno Club. Very interesting concept otherwise. Overall, among the baseline characteristics, as you can see, the patients with diabetes and hypertension had a severely increased ACR as a degree worsened. The comorbidities were quite significant with patients with higher albuminuria. And the most common causes of CKD in patients with higher albuminuria were glomerular diseases and diabetic nephropathy. Apart from that, all the baseline characteristics were overall similar. Around 85% of the patients were on RAS blocker, and this also increased as the degree of albuminuria increased as expected. And as the degree of albuminuria was increased, the GFR, estimated GFR, was also there, so which was as expected. Overall, for the study cohort, the median measured ACR was 354 milligram per gram, whereas PCR was 490 milligram per gram, when the overall estimated ACR was 230. So this shows that the median difference between the measured and the estimated ACR was around 139. And this difference increased as the measured ACR increased. So at a higher degree of albuminuria, the difference between the estimated and the measured ACR was clinically significant. And overall, the median values, it had shown that the ratio of measured ACR and PCR, it was significantly lower when the patient was having nephrotic range proteinuria as against those with proteinuria less than 1000 milligrams or less than 1000 to 3500 milligrams. The predictive performance of the equations for different disease categories with measured ACR, estimated ACR, and PCR area under ROCs were measured, and it was seen that irrespective of whatever type of albuminuria or proteinuria was being assessed, they were all similar for estimating the risk of kidney failure with replacement therapy across all diseases. It was similar for glomerular nephritis, diabetic nephropathy, hypertensive nephropathy, polycystic kidney disease, and also for unclassified. So irrespective of the cause of chronic kidney disease, the predictive role of either ACR, PCR, estimated ACR did not differ. And with regard to the CKD staging, in the earlier stages, in the stages 1 to 3, the significance, there was no difference between using measured ACR versus estimated ACR. Whereas in CKD stage 4 and 5, estimated ACR was inferior to both PCR as well as measured ACR in predicting the risk for kidney failure with replacement therapies. And the 5-year risk, it has shown that PCR and EACR perform better for predicting the 2-year risk than the 5-year risk. So the 2-year risk, we can use probably the measured ACR, whereas for the 5-year risk, either of the proteinuria values can be used. And for the PCR, the discrimination and the reclassification was better when the patients had nephrotic range proteinuria, and this did not differ across the various CKD stages. With regard to the difference in proteinuria values, estimated ACR was inferior in a subgroup with lesser proteinuria, which we had discussed earlier, whereas PCR was more superior when the measured ACR was higher. So we should avoid estimated ACR if the patient is going to have very less albumin-creatinine ratios. I guess lots of statistics were involved. I didn't go into the detail of each of them. To just conclude what was told, the predictive performance of each of these proteinurias, measured ACR, estimated ACR, and PCR, was analyzed for all patients. And when the kidney failure risk equation was measured, the 5-year and the 2-year risk were possible to be measured interchangeably using any of the other equations. The estimated ACR had inferior discrimination when various causes of CKD were compared, and if the albuminuria was of a lesser degree. Overall, the inferiority was greater in patients with lower albuminuria. This was what the estimated ACR had to. And for PCR, the performance is similar to measured ACR, especially apart from those with reduced ACR. So if the patient is going to have a reduced albumin excretion, then PCR should not be used. Whereas if the protein-creatinine ratio is, the proteinuria is higher, PCR can be used. So overall, the conclusion, the limitation was that this may not be generalizable to all primary care settings. And because the disease group may be varying in Korean patients as against the others, and also the non-American 4-variable KFRA may not be generalizable to our population, it is a problem. And there is no standardized method for overall measuring urinary protein and creatinine. So overall conclusion was that at lower albuminuria, measured ACR should be used, whereas at higher ranges, it can be used interchangeably. The choice between protein-creatinine ratio and the albumin-creatinine ratio should be based upon the local availability overall. Probably in this study, the role of visual abstract was very easy. So in mild albuminuria, both estimated ACR and PCR tend to underestimate the albuminuria, whereas in moderate and severe cases, protein-creatinine ratio probably is comparable, whereas across all stages, the estimated ACR underestimated the measured albumin-creatinine ratios.
You can stop sharing, Arun. And Vivek, do you want to go ahead and try again with your presentation, or I can share your slides? Yeah, you can start.
I'll just try.
Yeah.
So, Arun, thanks, Arun. You see my slides now?
No, sir.
No? Okay. So what I'll do is then
Yeah, you can stop sharing, Vivek. I'll share your slides. Yeah.
Do you see it now?
No.
No? Okay.
No.
I don't. What is the issue? Yeah, please, you do it.
Yeah. Yeah, go ahead.
Yeah. Good evening, everybody. I'm really sorry for this mess. I don't know what is the reason. But anyhow, we have few minutes left, and I'll quickly go through 2 articles. The first one was published in JASN. It's about one of the experimental drugs for hyperuricemia, which was for which there was some preliminary data that it was effective in reducing proteinuria in patients with diabetes in combination with allopurinol. So next slide. I'll not be able to, yeah, next. Yeah, thank you. So just a brief introduction of this drug, Verenurad. It's actually a uric acid transporter, urate1 inhibitor, and it decreases serum uric acid levels. And as I just told you that there was some preliminary data which suggested that it could reduce proteinuria in combination, not with allopurinol, but with febuxostat in patients with diabetes. That was a citrine trial. So this study actually, tested the safety and efficacy of this drug in combination with allopurinol in patients with chronic kidney disease and hyperuricemia. Next slide. So the inclusion criteria briefly included patients with estimated GFR more than 25 ml per minute with and proteinuria between expressed as urinary albumin creatinine ratio as between 30 to 5,000 milligram per gram and serum uric acid level more than or equal to 6 milligram per deciliter. So this is something which is very important in the context of CKD and hyperuricemia, that this is probably the first trial where you have a hypouricemic agent being used in the context of one of the inclusion criteria as elevated serum uric acid levels. The previous two studies that we have had in this regard, the CKD FIX and PEARL trial, which were published about 3 years back, which did not show any beneficial effect of allopurinol on progression of chronic kidney disease, actually did not have inclusion criteria as hyperuricemia beyond one particular level. But here we had a selection of individuals who had hyperuricemia. So they were randomized to one of the 5 groups, placebo versus allopurinol versus various doses, low, medium, and high doses of the interventional drug. And in addition, in the low dose group, after 9 weeks, after the 9th month, some of them were transitioned to a high dose of 24 milligram OD. Next slide. So this was a multicentric trial which was done in various centers in Europe, North America, and South Africa. Next. Importantly, individuals with autosomal dominant or autosomal recessive polycystic kidney disease, lupus nephritis, or ANCA vasculitis were excluded. So were individuals with HLA-B5801 allele, which predisposes to severe TEN-like reactions with allopurinol. Patients who were previous kidney transplant recipients, patients with a recent history of a cardiovascular event, as well as those with uncontrolled hypertension. In addition, patients with significant liver disease were excluded. Next. So this was the final consort diagram where we see that more than 800 participants were randomized to various treatment arms. Here we have 6 arms because few of the patients from the low dose group were transitioned to at 9 months were transitioned to high doses. So we have a separate group on that here. And I would just want you to focus on the number of dropouts. You see, if you see, there was significant number of dropouts across all the intervention arms, as well as the placebo. Next slide. So baseline clinical characteristics were more or less balanced across various groups. Next slide. So the primary objective was to look at change in proteinuria in the study groups, and as we can see that over 60 weeks, approximately 1 year duration, the change in proteinuria across various groups was not statistically significant. Next slide. This also more or less reflects the same. Next. And a subgroup analysis, depending on age, sex, the region where the study took place, diabetes status, baseline eGFR, and baseline protein excretion, urinary albumin excretion rate, as well as serum urate levels, did not actually, show any difference or any trend. So it was more or less like universal that the drug was not helping any of the subgroups or any of the patients with some special clinical characteristics. Next slide. Now, this goes on to show that across the various study groups, as one of the secondary objectives, they looked at the change in the estimated glomerular filtration rate. And as we can see in this, that this also was something which is, of course, very, very, very much clinically relevant, but did not change significantly between the groups. Next. This is the serum uric acid levels graph depicting the serial change in serum uric acid levels. And as is on expected lines, that compared to the placebo group, we had decrease in uric acid levels in all the intervention groups. It was more so in the combination group. Next. So in conclusion, so this So the study shows that that a combination of Verenurad with allopurinol did reduce serum urate levels, but it did not reduce albuminuria or decrease the eGFR decline in patients with chronic kidney disease and hyperuricemia with or without diabetes. Next. So I'll quickly come to the second article, which is actually looking at, it's a phase 2 study which looked at humanized monoclonal antibody, anti-CD40, blessilumab, in preventing recurrence of primary FSGS in kidney transplant recipients. Next. So I'll just skip this slide. So there is some experimental data to suggest that CD40 and CD40 ligand interaction might be implicated in, in protection against in vivo induction of FSGS. So this drug is a proprietary molecule of Astellas, and they had some preliminary data to suggest that it might be effective. So this was a phase 2 trial which looked at the safety and efficacy of this drug in patients with patients who are predisposed to develop recurrent FSGS, that patients with primary FSGS. Next slide. So this was a study which was done in Canada and US, phase 2 randomized trial. So next slide. I think we are already. So patients, so briefly, we had patients with primary FSGS who were receiving a kidney transplant, either living donor or deceased donor transplant. They were randomized to receive either standard medical care, which included, induction with basiliximab and triple immunosuppression, versus, induction with basiliximab and tacrolimus steroids and the investigational drug. Now, this drug was given as an intravenous injection for 12 months. It was given at baseline. For the first time, it was given intraoperatively. Thereafter, at day 7, 14, 28, 42, 56, 70, and 90. And after month 3, it was once every month till 12 months. So the dose was 200 milligram per dose. Yeah. Next slide. So importantly, the group of individuals who were excluded from the trials were patients with secondary FSGS, patients who had received an organ transplant, and their most current graft failure was not due to recurrence of FSGS if they had FSGS as their basic disease. And if the patient had received an induction therapy, which was other than basiliximab, patients with kidney transplant as part of a multi-organ transplant, or patients who received a dual kidney transplant from deceased donor, and patients who received a kidney that qualified the criteria for both extended and DCD. Also, individuals with calculated PRA levels more than 50% were excluded. Next slide. So a total of 67 patients were randomized to standard of care and the blessilumab group. Ultimately, for full data analysis, the full analysis set included 33 individuals in the standard of care versus 27 in the interventional group, and the safety analysis group set included 34 and 29 respectively. Next slide. So at baseline, they were more or less equally balanced, except for the fact that individuals in the blessilumab group, they had slightly higher calculated PRA, but when looking at the categories, it was not significant. In absolute levels, it was significant, but otherwise the groups were fairly balanced. Next slide. So as we can see in this chart, which depicts the the serial change in the overall incidence of recurrent FSGS. So actually, they defined it in 3 different ways, in the sense that they did 3 different types of analysis. One is that they just looked at urine protein excretion rate, and a UPCR of more than 3 gram per gram was taken as something reflective of recurrent FSGS. Then they had another group where it was defined purely on the basis of pathology on allograft biopsy. And there was a third group where, in addition to urine protein excretion rate, all those individuals who had death, graft loss, or who were lost to follow-up, they were imputed as, as having recurrence of FSGS. And as we can see, over the 12-month study duration, when these outcomes were analyzed at 3rd month, 6 months, and 12 months, we see that numerically there is indeed a reduction in the incidence of recurrence FSGS, as is defined by these different these different definitions. There's indeed a difference in the intervention group, but the difference was not statistically significant. And we can see that demographically, with respect to sex and race, there were not much difference in the groups. Next slide. Similarly, the use of ancillary therapies like ACE, ARBs, or B cell depleting agents like rituximab and plasmapheresis in the two groups was also not statistically significant. Though we must realize that the numbers are really, really small here. Next. One of the most important secondary objectives was to look at biopsy-proven acute rejection. So numerically, it was slightly higher in the intervention group, but overall, it was not statistically significant. The numbers are really low, like 7 in each group by the end of 12 months. So not much in it. Next. Overall, the incidence of efficacy failure, which again is a combined endpoint, which was a combination of rejection, graft loss, death, or loss of follow-up, also did not show any significant difference. Next. With respect to the treatment-related serious adverse events, there was no significant difference between the two groups. Next. So in conclusion, this combination, this interventional agent, blesilumab, did reduce the occurrence of proteinuria, but it did not reach statistical significance with respect to its use for preventing post-transplant recurrence of FST. I'll just stop here. Thank you.
Thank you. Thank you, Vivek. I now invite Anupama Madam, Professor at the Sanjay Gandhi Postgraduate Institute, Lucknow, to share her critical thoughts about all the studies. Over to you, ma'am. Hello, madam. Yeah. Ma'am, I think you need to unmute yourself.
Am I audible now?
Yeah, audible now. Yes, ma'am.
So there were excellent articles which were presented today, and each had a critical explanation for each of them. The one with the accelerated vaccination protocol versus the standard protocol in the advanced hepatitis B vaccination. We do see that the protocol of accelerated vaccination did make a difference in the earlier group, although the primary endpoints were assessed at 12 weeks, which were the time period when the standard protocol was not able to complete its vaccination protocols. So the point here is that they did have an improvement in the antibody titers, but it wasn't sustainable. And secondly, if you look into the data, there was almost 17 patients, almost 12.9% of the patients who actually had been the ones who had also been in the past been vaccinated. So a single dose of a booster would have definitely made their antibodies to go up. So that's a point in the first study. And the second one, the implication of the biopsies in the living donor. So there is so much of data suggesting that the intimal as well as the interstitial fibrosis, which happens in the donor much before they are transplanted, has an implication over the overall outcome. But then, of course, the data has clearly shown, this study has clearly shown that the chronic changes in the biopsy, which was there in almost 14% of the patients, didn't have a long-term implication, and whether atherosclerosis and the higher age was the contributing factor in the past studies does make a difference. And then, of course, the significance of hematuria in patients in prediction or CKD. Well, this is quite known that patients who have hematuria, they do cause changes in the filtration barrier and cause injury. And then we must also see that the problem here is that the population of patients who had MGN were quite a proportion of population in the patients when we had seen them. And of course, the remission rates were much more higher who had presented with earlier hematuria and a lesser degree of proteinuria. And then, of course, the newer drug Verenurad, which with the combination allopurinol did studies have shown in diabetic kidney disease that they did show some decrease in proteinuria. And however, this study didn't show that much of improvement in terms of decreasing the proteinuria. But then, of course, the hyperuricemia was taken in care, but larger studies are required. And of course, the CD40 antibody and its implication in FSGS is a newer drug which is coming up, and we need more studies on to looking up this aspect of the drug having its effect on its overall outcome.
Thank you, Pranam. There were a couple of chats because of the limit of the time. We have answered most of the queries in the chat box. There's one question for Vivek. Vivek, why in FSGS article induction other than basiliximab were excluded? Any reason? Did you find any reason in the article?
So I did go through the separate protocol also. I didn't find, but probably it was because induction is such an important part. So probably it was just for the purpose of I would say balancing subjects in both the groups with respect to induction, which we know is actually a kind of immune therapy. So that is the possible reason that that induction agents were restricted to one only.
Okay. There was another question. Does age-related chronic histology have same implication as disease-related chronic changes? Sir, in one of the articles from the Mayo Clinic, which did donor implantation biopsy, they said that it is more important to look at the glomerulomegaly, the glomerular number, as well as the tubular cell number, rather than just IFTA or sclerosis, because those tell about whether it is a chronic histology or whether it is a disease-related chronic changes. And they said that, yes, that is more important. I mean, the disease-related chronic changes have more rapid progression, both in donor as well as in recipient, than the chronic histology, age-related histological changes. And any other queries? Can post it on the chat box and we'll reply it. Thank you all for joining. Thank you, madam. Thank you, Anupama, madam, for being there and supporting the Indian Society of Nephrology Journal Club. Thank you, Vivek. Thank you, Arun. I think we can. We are 9:10. I think we can end the session here. Thank you.
Thank you. Thanks a lot.
Thank you.